So Kelly, you had some data showing that the people that were more likely to have various types of insurance were more able to achieve an undetectable viral load on treatment. Can you sort of describe that for us?
Sure. Well, first of all, we looked at whether people had coverage at all, and we found that those who did, 96%, were more likely to achieve viral suppression. Then we looked at coverage by type, so there were 6 main types, and we found that, in fact, type is associated with viral suppression.
And what were those types?
We found that those who had military insurance, so TRICARE, CHAMPUS, VA coverage, as well as those who had Medicare coverage, were more likely to achieve viral suppression.
Okay.
We found that people who had other types of publicly funded insurance, so not Medicaid or Medicare, but things like city, county, and state-funded public insurance, were less likely to achieve viral suppression. We also looked at private insurance, Ryan White coverage, and Medicaid, of course, coverage, and we found essentially null associations.
So people who got their care, say, through ADAP didn't have a difference?
We considered Ryan White and ADAP to be the same category, so people have different notions of what that means, but whether people got health care coverage or coverage for their medications, antiretrovirals, that was lumped into one category. And those people did no better or worse than the other, relative to the other types of insurance.
Okay, and what might you say about why the military coverage people on that might have done better?
Well, I'm not a clinician. I've not spent a lot of time in the VA or clinics at all, but I did get some feedback on my poster yesterday, and people weren't at all surprised by that. It was the sort of one-stop shopping. People know exactly where to go for the whole continuum of care, meds, primary care, HIV, particular care, and I believe it's not hard to keep your coverage consistent. So other forms of coverage, you have to get re-enrolled every so often, where I don't believe that's true for the military types of
And did
coverage.
you, it looks like your population was mostly covered by some form of insurance or another. How do you think what implications might it have for people who have poor or no coverage at all?
Right, so I will reiterate that point. So these are people who are recruited through facilities where they're getting care. So they're in care by definition, and you would expect that they have higher rates of coverage. We know that not all HIV infected folks in the US do. So we have to keep that in mind. These results are not entirely generalizable for that reason. Can you remind me of the crux of your question again?
Sort of like what are the implications for people who might not have coverage? Can we say that having coverage is presumably it is better, but do your data support that? They
do, in fact. I mean, that's intuitive, of course. We know that the easiest way to viral suppression is through medications as well as comprehensive health care. The easiest way to get that is through comprehensive insurance. And so we're not exactly surprised by this. However, MMP data, Medical Monitoring Project data, are special in that they represent the entire nation. And so these are important estimates for that reason.
And what will your sort of take-home message be about what this means for public policy?
Well, I would say that this population happens to be covered to a large proportion, but we know that's probably not true for all HIV-infected persons. We see a difference by type, and so I think examining quality of care differences by type is an important next step. We don't describe that in detail in this analysis, but we do acknowledge that there are perhaps differences across the nation as well as across types of payer source, and so understanding those better and how they relate to successful outcomes would be an important next step.
Great. Well, thank you for speaking with us.